quick and crisp introduction. I'm going to take you through these points, but before I start this, I want to know how many of you have written GLP-1 ever in your practice, ever? So I see 70% of you have not raised hand. So 70% have not written a GLP-1 ever? Then you are in the right hall, absolutely. My next question to you, which was the first GLP-1 which was available in the world? Exenatide, very good. Which year? Not chairpersons, I know you know the answers. Rutul and Vipul and Dr. Lutika will not tell the answers, yeah. And even Ruvi also will not talk, she's there in the... Huh? 2005, Exenatide as the first GLP-1 was available in the world, and after 2 years, Lilly brought it to India 2007. So, GLP-1s are not new molecules. The first thing we learned today, they are older molecules. Second thing, since when it is available in India? 2007. Which GLP-1 has the longest record for CV safety, cardiovascular safety? Anybody? You may have not used, but you may have heard. Longest CV safety by any GLP-1 trial till today. It is Liraglutide. Longest till today. Even Sema and Tirzepatide are the lesser ones over there. Now, with that, let us delve into how do we use and place this molecule, and why is it that despite being availability of such high-grade molecules, such stronger molecules, we suddenly have an API consensus statement on Liraglutide. For that, we need to understand a few slides. Why is it that there is a health implication with diabesity? This is not a new term for us. We have had diabesity when this term was launched. I have taken this session in the next hall, the right to our right, the Sadikot hall. We discussed in detail about diabesity, what was it few years back. And it is important that it reflects the link between obesity and this, diabetes. The unmet need basically is that the prevalence is increasing. We need to optimize the treatment, give as less as possible. When you have a patient of type 2 diabetes, the first thing we tell the patient on day 1 is there are 2 types of treatment. One is injectable, second is oral. In injectable, we have A, insulin, B, something which can match with your insulin requirements and also with your weight requirement. That is where we say. Second, if you have obesity, then the graph molds a little down over there. 20 years we've been showing this slide on Liraglutide, which is one of the long-acting. Somebody said Exenatide, Lixisenatide, they were twice a day or thrice a day. But the first long-acting 24 hours working was Liraglutide. This is how it was used. And now we have a biosimilar Liraglutide, which is made in India, make in India. Can anybody tell me when was the first Indian Liraglutide available? 2024 or late 2023. So roughly Jan 24, I think we started having Liraglutide for our own population. A very good part is the question that we asked, is it same in efficacy as the innovator or the originator molecule? And that is where I'm showing you the first study, PK data and phase 1 data with similar and biologic Liraglutide, both the innovator molecule. This is the second study that I'm showing you, which talks about the efficacy of similarity between the biological and the biosimilar molecule, 128 patients. We need to have at least 70 to 100 patients. This was 128 patients which showed this data. And I'll show you in the next slide there, efficacy in reducing HbA1c and efficacy in reducing for both over here, from baseline till 12 weeks and till 18 weeks and then till 24 weeks. So here we are clear about A. The first long acting was 24 hours was Liraglutide. The longest trial with heart CV safety is this drug, and we have 2 senior endocrinologists in the hall, Dr. Parag Shah and Dr. Manoj Chadda. Both will agree with me that yes, we have used this biosimilar and it has shown the result, it has shown the outcome and how you move ahead. Even the secondary efficacy data, if you see the comparison between the two, was nearly similar. and the comparative effects of both composite and outcome incorporating glycemic control and others also talked about that it was similar when you look at this. Now, I will show you 3 more sections of the slides, one with only diabetes, one with only obesity, and one with a complication of obesity. So we have very high efficacy, as I said in the start, sema and tirzepatide. But remember what we had, the long-term or the first long-acting lira and the first weekly doula, followed by others which are not listed over here, but somewhere they are available. And we also see that their efficacy and their post-hoc analysis, we talk about nearly 180 patients of obese as per the current standards, and we say that yes, they were effective. In MAFLD, there is a data, there is a meta-analysis, good amount of studies, good number of studies for MASLD, and we talk about again there that compared to placebo and others, it improved BMI, lipid parameters and others. Now, the question is, such a big cry, such a big view about all those newer drugs suddenly, but believe me, when a doctor starts these drugs once weekly, those which are very costly, and those who have a lot of GI side effects, what will you do with them? We need to give them an answer. People with dual agonist or a once weekly very high grade agonist, when they have GI side effects, the answer is their long-term issue of once in a week dosing. Here, these are the patients where you need to cut down and talk about that you give for short-term single daily dose and monitor accordingly. Maybe when you need a short washout, we need to give it for a short term, we use this kind of a drug. And of course, out-of-pocket expenses. In US, in Europe, in Australia, others, it's the insurance which pays. Here, we are paying. While I was entering in the hall, a lot of people said, sir, I am very happy in writing these newer molecules, but patients are refusing. But only your patients are not refusing, my dear. Across the world, in the study also, there have been a lot of dropouts with these drugs. In real world studies, within 1 year, people have dropped out of these long-acting weekly molecules. So what we come down again is with this. Benefits, cardio and renal. My previous speaker, Dr. Apurva, will agree with me that this also was shown earlier with the innovator and now also with this, even in CVOT and meta-analysis, it showed a strong protection with CVOT of GLP-1RA. Some of you will say, no, exenatide was launched earlier, but exenatide study showed non-inferiority. It was liraglutide which showed superiority in CVOT. So that's where we have a strong confidence for this particular molecule over here. And that's where it is important. My next question is, do we have a data on stroke also? Did it do that? This is the first Chinese study I am showing, around 650 patients, 600 odd patients, where it was a lab study and where it showed that yes, you can see the endpoint, the primary endpoint with newer strokes within 90 days was not there, and it was as efficacious as any other promising option for stroke prevention. I think with the meaning of CVOT, we only get carried away with heart, but we somewhere forget the lower limbs, we forget kidneys, we forget the stroke. So this is one evidence that we talk about. So liraglutide in the management of diabesity. These are the following summary slides for those who have just joined us right now. Before I go to actual the API position statement, why this talk was kept, I want to know how many of you use paracetamol, whether 500 or 650 mg daily for fever? So 99%, I think chair and organizers are looking at those hand raises. Number one, I want to tell you, GLP-1 drugs are not a phone prescription. They are properly to be used like an anti-cancer drugs, even if you are using it for your own relative or you are using it on yourself. They need proper evaluation. A doctor will fail if you have not asked for a history of medullary thyroid carcinoma or a familial medullary thyroid carcinoma in the first appointment when you even plan to start this, because that is an absolute contraindication. You fail to ask this question, medico-legally you are in jail. Remember, we are entering in a medico-legal era and pharmacovigilance is going to be very, very important. So that's an important thing. I gave you example of Dolo because people are using it like Dolo, and I want to tell you, Liraglutide is the Dolo of anti-obesity treatment. It's going to be cheap, it is available, it is Indian made, efficacy is same. Right now what we have other drugs of 14,000 basic dose, Liraglutide now the basic dose is 3,000. Now you will say, some smart person will stand up and ask me in the session, no, but from March, SEMA, this is coming. So Lira will go one step ahead. From March we have Lira further coming down as cartridges. So it will be still 10 times cheaper than even after your this thing. That's the reason the API position statement about its growing evidence-based framework, about use in diabesity, use in type 2 diabetes, using others. A lot of infertility doctors are using this to treat their patients pre-IVF. The washout period for semaglutide pre-IVF is 8 weeks. For tirzepatide it is 4 weeks. But for this one, it is much easier when during those days you give a shorter injection. And I also see a lot of patients with second and third opinions that my doctor has given me this is 6 months, I don't want to use any further. This is that drug, number one. Number two, a lot of patients sit in front of us and ask, doctor, is there any side effect of the drug? You have to say, yes, there are many side effects. From giddiness, from hypoglycemia, from your right side gallbladder issue, from your left side pancreatic issue, you need to tell everything. Another thing with the intestine, anybody, what is the side effect with intestine? Stomach paralysis can happen, intestinal paralysis, we have seen a lot of case reports. And if you give in patients with retinopathy and you're not monitoring with a rapid weight loss, you're not adjusting the dose, you may have Mayon also, right? Luckily with Lira, we have not seen a lot of Mayon, we've used it. But remember, there is no shortcut to weight loss. Even when you're using it for your relatives or you are using it for yourself, you need to get evaluated and keep eye, be vigilant pharmacologically to move ahead. So those were the recommendations and the guideline. So whatever slides I have shown and whatever I have discussed directly or with an interactive question is all there now on this slide. Diabetes and obesity, this should be one of your important drugs to be given, diabesity, along with other first-line drugs. Adults with obesity with or without visual complications like hypertension, dyslipidemia or pre-diabetes, also this. And it should be used only. Now this is the most important line. You cannot have the lunch that served by Dr. Banshi Sabu and then take a liraglutide injection. You need to monitor your portion control, right? Dr. Dhruvi is smiling, she's like, yes, aaj kam rakha hai, she's saying. So if you see that a menu is less in today's lunch, it is not because of this lecture. Risk-benefit consideration is very important. I'm done, 60 seconds more. Why and when you would do, you will always monitor pain abdomen, eruptions, constipations, etc. need to be monitored. Always tell the patient not to have food with strong aroma. For example, foods which contain a lot of ginger. For example, a food like a biryani, not to have too much after the dose, because the first 2 or 3 days are going to be really important when you control these side effects. I think with this particular API position statement, I leave it to you to click pictures, think over it, and I give the session back over to organizers and I wait for any questions, if at all. Else let me know, do I need to wait or go? Thank you so much, ladies and gentlemen.